So is there special care that needs to be taken in treating someone who's a recovering addict with significant periods of sobriety in an acute setting in which narcotics are required? So I guess somebody who had been previously addicted to an opioid and now is clean, but now they need to actually get narcotics.
Yeah. So this is an example of one of the reasons why treating an addiction can be difficult, because, for example, in the case of pain medications or opioids, they serve very important, helpful uses as well. So pain medications are used by doctors for patients to treat pain. And all of us will encounter pain at some time in our life, unfortunately. And so for someone who is already addicted to pain medications, it may be hard to avoid exposure to something which is medically necessary. Okay? And so I see this situation very commonly in hospital. And the answer is yes, special care does need to be taken for people who, let's say, have a previous history of addiction to a painkiller, who have been clean and sober for a long period of time, and now break their leg. Now, in the old days, some of us would think, well, maybe we don't use opioid pain medications, but there really aren't a lot of other good alternatives when you have really severe pain, okay? Which means you have to use the pain medications. The question is, how do you use them in a safe way, okay? The safe way to use them is to, number one, have it prescribed by someone hopefully with a lot of experience, or someone who has access to someone with experience to give them some guidance. Number two, close monitoring to see if the use of the pain medication starts to get out of control, or there are early warning signs of it, that it can be recognized sooner. Number three, making sure that the medication is used for the right reason, okay? So for example, when someone is addicted to a drug, they may use it to get high, they may use it when they feel sad, they may use it when they feel angry, they may use it when they want to sleep, in the case of pain medications. So it's a matter of making sure that the person is using it for the pain and not for other reasons, and as a doctor, talking to the patient to see if there are other reasons why they're using it, because they're using it for other reasons. That might be an indication that maybe things are starting to get out of control again, and therefore we would want to intervene before all the wheels fall off of the car.
So this person is worried about why do some physicians push opiate pills such as Dilaudid after surgery, and this individual feels that that was an inciting event that started them to be getting an addiction problem, but they're in recovery now.
Yep. So it depends on, number one, surgeries result in a lot of pain, okay? And different types or families of pain medications have limits to how much pain relief they can provide. So the opioids are some of the strongest pain medications. Some of the other ones that are non-addictive, unfortunately, cannot provide strong enough pain control. So therefore, surgeons commonly or usually will prescribe opioids. The key is using them carefully, okay, and with close monitoring. The other thing is that if you are on a pain medication or an opioid for a long enough period of time, if you were to stop it abruptly, your body will go through physical withdrawal. That doesn't mean that you're addicted to it. So if I break my leg skiing and I need to be put on morphine for 2, 3, 4 weeks, if I stop it all of a sudden, I will go through withdrawal. That's a normal reaction or response of the body. So when we put someone on pain medications, if they're on them for a long enough period of time where the body could respond with withdrawal, it's important that the prescribing doctor gradually reduce the dose rather than stopping it all at once. By gradually reducing the dose, you reduce the risk of development of withdrawal, which A, could set off an addiction, or B, for someone who already has an addiction, could be a triggering event to relapse back to drug use.
So, what is a good way to get dopamine release, just like a high, without using any substances?
Sex, food, exercise, for better or worse, depending on your point of view.
All in moderation and safely. Yes. Okay. So this person had never done drugs before and had a good upbringing and was adopted by parents who never used drugs or drank to excess or smoked cigarettes. However, this individual's birth parents both had addictive problems, and this person wonders, was it inevitable for them to become alcoholic and addict? Why? What's going on in someone's brain?
Yeah. So when we look at when we look at sort of the risk factors for addiction, genetics does play a role, as I mentioned with the example of alcohol. Now, genetics doesn't explain it all, so it's not 100%, meaning that if I have an addiction and then I have a child, my child doesn't have a 100% chance of having an addiction. Okay, if you actually look at the research, that my child would actually have roughly a 33% chance of having an addiction. Okay, so genetics does play a strong role, but it doesn't explain everything. As I mentioned with all those other risk factors, it's not just about the genetics, it's also about other features within the person, but also about the environment that they're in as well. And even despite all that, you could have the perfect genetics and the perfect environment and still end up with an addiction. So there are no guarantees.
So what are the main reasons why methadone is used in aiding heroin addicts? And is methadone easier or harder to get off of?
That's a commonly asked question. Methadone is in the same family of opioids as morphine would be or heroin would be. The difference is that methadone is a very long-acting medication that we get from the pharmacy. And so, number one, because it's long-acting, you only need to take it once. Most of the opioids like heroin and morphine are short-acting, so it has to be used multiple times throughout the day. And so in the case of heroin, injecting 2 to 3 to 4 times a day. And so a lot of time is spent around trying to get the money to buy the heroin. A lot of time is spent looking for the heroin. A lot of time is spent using the heroin and then recovering from the high of the heroin, okay? So the whole day revolves around heroin. But if you can get away from the withdrawal from heroin by using methadone once a day, then you don't feel withdrawal because that methadone is in your system for the whole time. So you don't feel sick or what they say, dope sick. And therefore, you can start to use that time for better things. Is it harder to get off of than heroin? No. A lot of people think that because methadone is a longer acting medication, it takes longer for the methadone to leave the system, and the withdrawal period lasts a longer period of time, although the intensity is lower. But overall, it's not easier or harder. The difference, though, is with methadone, many people can lead very normal lives and go to work and raise families, but it's much harder to do that because using the short-acting opioids is a much more chaotic life.
So you haven't mentioned OxyContin and wondered why it wasn't addressed, as there appears to be increased street use and including injection.
Yep. So I did mention it in general in the form when I talked about the fact that the prescription opioid drug use has really been escalating. And prescription drug use would include things like prescription oxycodone in the form of Percocets and Percodans. And so definitely a major problem.
So what's better, smoking medicinal marijuana or taking the THC pills?
That would be a 1-hour talk by itself. And I actually have that talk in my computer. So maybe if someone wants to have that as another future let's talk about, we can do that. But that's a really long answer.
Okay. So maybe if that person's interested, you might be able to come up to Dr. Chan afterwards and he can
Yeah.
give you a shorter summary. Okay. What's your position on the use of medicinal marijuana for severe arthritis?
That's a very, very good question. Again, that would be part of my 1 hour talk. The long and the short of it is that research shows that there are medicinal uses of marijuana, okay? What is often quoted is that there isn't a lot of scientific evidence to show the benefits of marijuana. That is true, but you have to understand why it's true. The reason why it's true is that for many, many years, scientists have not actually been allowed to study medical marijuana. It's been very difficult for research to actually get marijuana to use for test subjects. And it's only been really more so in the last 10 years that it's become more readily available for scientists who have to get approval from the government to study it. So it is being studied much more frequently now. But that's one of the reasons why there isn't a lot of scientific evidence. Of the studies that have been done so far for other purposes, there is benefit. Now, specifically for arthritis, we would have to balance the benefits, pain relief, versus the potential complications. Just like with smoking regular tobacco cigarettes, there are long-term health consequences from smoking marijuana long-term. There's a lot of debate about how great those risks are compared to tobacco. But if we're going to be treating a long or chronic condition like arthritis, we have to balance that out with what will be the risks of its long-term use. And so, again, that's the short answer, but the long answer would be
Another talk.
another talk.
So if conduct disorder is a predisposing factor for later substance abuse, does this mean substance abuse in the adult population is highest among those who have an antisocial personality disorder?
I don't know if it's highest, but it is very high. There's no question about it. It is like if you took a group of 100 people with no conduct disorder, and then you took another group of 100 people that have conduct disorder, addictions will be much more prevalent in the conduct disorder group.
So this person describes his daughter is almost 34 years old, and she smokes marijuana daily since she was 13 and a half, and wants to know what strategies could he have or she have to help convince her to stop her addiction.
Okay. When we look at treating different kinds of addictions, I can talk about that here. There are different strategies that are used, okay? For example, one strategy is detoxification, which means getting someone to stop using the drug, supporting them through that difficult, short period of time when they may go through withdrawal, for example. Another strategy is called relapse prevention, and that's what do you do with someone once they've actually stopped, okay? And there are different treatment strategies, those that include medications and those that do not include medications, okay? So the treatment or the strategy for an individual like this kind of depends on where they are at right now. Have they actually stopped using yet? Do they want to stop using? And also, what is the environment that they're in? So I can't give you an easy answer for that. The one thing that I would say is that it's really important for you to maintain your relationship with your loved one, regardless of whether that person continues to use or doesn't use. It's important to maintain a healthy, supportive relationship, a loving relationship, because that can be very important to them. The other thing that I would recommend is that the parent find out as much information as they can about the problem. That way they can help themselves deal with the daughter having the problem, regardless of whether the daughter wants to deal with the problem or not. So for example, we all know about Alcoholics Anonymous for people that drink alcohol. and that is group support for people that are trying to recover from alcoholism. But there are also support groups for families of alcoholics. Has anybody ever heard of Al-Anon? Okay. So again, that's support for family members or friends of people that have an addiction. The father, in this case, may not necessarily have total control over whether the daughter stops or not. So regardless of whether the daughter chooses to stop or not, the parent still needs help with the problem. Okay.
So, have you heard anything about a gene that some people may have that causes psychosis if you smoke marijuana?
Yeah. So one of the questions is always, and this is also in my marijuana talk, let me just, there's, yeah. So I was going to show you a picture of an ad for a movie called Reefer Madness, okay? Reefer Madness was a movie that came out, I believe, in the 30s about the harmful effects of marijuana and about how it makes people crazed killers. And so one of the things that parents always tell children about is don't smoke marijuana because it'll make you crazy, okay? So it's sensationalized in this movie, which to us now looking at it is very comical, but at the time that it was produced was meant to be a serious movie. But anyways, with a lot of stories, there's often some truth to the story, okay? And when it comes to marijuana, we do know that heavy marijuana use earlier in life does increase the emergence of psychotic problems, including schizophrenia, okay? That's been shown in many, many different studies. Now, that doesn't mean that everyone who smokes marijuana becomes psychotic. In fact, very few actually do. But basically what we're saying is for people that are already, let's say for genetic reasons, at risk of developing a psychosis, so for example, if you have a family history of a loved one, especially a close relative who has schizophrenia, if you choose to smoke marijuana, your risk of turning on a trigger in the brain that sets you onto the path of schizophrenia may get turned on. That won't get turned on or has a less likely to be turned on if you're never exposed to hallucinogens to begin with. So there is some truth to that.
Okay. So two questions that are related. Is addiction a disease? And then is the brain different in an addict versus a non-addict?
Very good question.
Yeah.
With respects to is addiction a disease, that's been an area of education that's come forward over the last 20 years, which, as simple as it sounds, has actually been a very big breakthrough in changing attitudes and perceptions about addiction. Is it truly a disease, or is that just PR work? The answer is yes, it is a disease. Okay, it's a disease in many ways. As I was saying, there are genetic predispositions to developing addictions, and genetic predispositions means probably somehow differences in the brains of people that are addicted or who are at greater risk of addiction. Do we know exactly what those changes are? Not really, because we don't really know all that much about the brain yet, right? For our knowledge of what really goes on in that jello brain of ours is very limited compared to what really happens. Eventually, we may find that out. Let me get back to my talking, because I actually have a slide that answers this question. The other thing is that not only may the brains of addicts be different before they use drugs, which predisposes them, but also the brains of addicts are different when they're actually using drugs, and also are different after they stop using the drugs as well, which is why it's not simply about saying no, because it's harder for the brain to say no because the brain is a little bit different. And one of the ways that we're understanding more and more about the brain is by different types of scans or imaging of the brain to see how the brain works. Again, but it's very crude. But this is an example of a study of what happens to a brain of an addict. In this case, the addiction is to tobacco. Okay? On the far left would be a non-smoker. And it may be hard to see, but you'll see that there's more blue color in the brain, okay? In the person who's a smoker, which is the next one over, there's less blue, more green, okay? And what this is looking at nicotine receptors in the brain, okay? And then they follow the brains, a week, 2 weeks, a month out after they've stopped smoking to see whether the brain looks back like it did compared to a non-smoker. And what this study shows is that it took 3 months before the brain started to look normal compared to someone who's a non-smoker, okay? This is, again, just one chemical in the brain, so just one effect that someone who's addicted to cigarettes had on their brain. To give you another example of the hard wiring that can occur in the brain, if you do some sort of imaging using different chemicals in someone who is actively using cocaine, it'll look a certain way, okay, compared to someone who doesn't use cocaine. If that person who is a cocaine addict stops using for 1, 2, 3 months, maybe up to 6 months, it's going to take time for that brain scan to look like the person who doesn't use, kind of like with tobacco here. But if you show them a movie of someone smoking crack cocaine or injecting cocaine or snorting cocaine, and then you take an image or a picture of their brain, it'll look exactly like the person who's actively using cocaine, even though all they've done is look at a picture of it. So that shows you how strong that connection is that's been formed between cocaine and pleasure and the motivation to want to use. So again, even if that person hasn't used in a long time, and even though once you show them the picture, they haven't actually used the cocaine yet, and their brain is already looking abnormal like it did when they were using. So that, again, shows you how powerful those connections are.
So would ingesting food made with marijuana get rid of the risks of using medicinal marijuana that are compared with the tobacco risks?
Yes, it could actually. There are probably the biggest concerns or health risks about the use of medical marijuana is that most medical marijuana is used in smoked form, as I was mentioning earlier. So therefore, similar concerns to tobacco smoke. Another way of using medical marijuana is to ingest it or eat it. A lot of people, for example, will make marijuana butter. Okay, what you do is you take butter and you take marijuana preparation, usually in the form of hash oil, and you cook them together, and then you let the butter harden, and then you've got butter that you can store in the fridge, you can bake with it, you can put it on toast, etc. The problem with that is that you don't get as big a bang for the buck. Okay? Smoking is an excellent delivery mechanism because it gets into the brain really quickly, okay? If you eat marijuana preparations like magic brownies, for example, or what happens is you eat it, your body digests it, and then the marijuana chemicals have to go through the liver first, okay? And unfortunately, the liver will break down most of the marijuana ingredient before it actually gets to the brain, okay? That's why most people that abuse marijuana prefer to smoke it. So if you only have $100 worth to spend on marijuana, to get your biggest bang for your buck, you'd want to smoke it, not eat it. But yes, it would provide some reduced harm. The only other problem with eating it as marijuana is that the other nice thing about smoking as a mechanism is that you can titrate very quickly. So if you start to get too high from it, you'll sense that faster, and then you can stop so that you get the benefit, like for example, pain relief or nausea relief, without it making you high if that's what you don't want. But when you're eating it, because it takes time before you feel the effect of it, there's a greater chance of you getting the wrong effect from it because, for example, you may take too much. Okay?
So these are related questions. So why do people continue to use ecstasy when they know it can kill you? I guess with the most recent rash of fatalities. But also, they wanted to know what you thought about the Vancouver Police Department refusing to release descriptions or markings on the recent batch of poison ecstasy that contain a lethal additive that's led to 5 deaths, because they're worried that it would seem like sanctioning the rest of the ecstasy pills for consumption by users in Vancouver.
Okay, so
Why do people take it?
there are several questions about. So why does someone use a drug that they know will kill them or could kill them? That is the whole essence of addiction. The thing about addiction is the thing that really characterizes addiction is loss of control. Okay, and when you've lost control, the fact that it could kill you doesn't necessarily make you stop. In fact, most of the people that I see who have addictions, very serious addictions, and have had very serious consequences of their addiction, know that in some way it's killing them. Even the people that we see in hospital with the most severe medical problems, even while we're actively treating them, some of them are still actively using the drugs that caused the original problem. And again, that just shows you how severe the problem of addiction is, how strong that change is in the brain that makes you want to use it. So it defies common sense or logic. When I showed you that picture of the brain, I showed you the reptilian brain, which is almost the automatic. The larger part of the brain, which is the cerebral cortex, that's where reasoning comes in, right? But the reasoning part is trying to fight against a stronger, more basic urge, okay? So reason doesn't always win out, right? And as far as the ecstasy, so the funny thing about ecstasy, well, I guess it's not funny, but this is actually not a new story. A lot of what is sold as ecstasy is not ecstasy. And that's been going on for as long as people have been using ecstasy, okay? Unfortunately, a lot of times what is sold as ecstasy is actually an amphetamine with a real stimulant property, as opposed to ecstasy, which is related to the stimulants but has a different effect. And like, for example, there's a lot of methamphetamine in what is sold as ecstasy. Now, there are some places, more so in Europe, there are some places which will provide services for people that are out at the clubs buying drugs and using them. And the service is, if you give them a pill, they will analyze it for you and tell you what's in it, whether it really is ecstasy or not ecstasy. Unfortunately, that process takes a lot of money, takes a lot of resources, and takes a lot of cooperation to be able to do. And that's why that service is provided more in Europe than in North America. And those services are usually provided by people that are advocating for people that are using drugs and want them to be safe. Those programs usually are not put on by government for political reasons, okay? And that would be the best way of identifying whether that drug is harmful or not. I think it would be helpful for them to show the pictures of the drugs. As when I showed you the picture of ecstasy, I wish there was an easier way of going through this, but when I showed you the picture of the different ecstasy pills, what you'll see is that it can come in different colors, shapes, sizes, and they have different stamps on them, okay? Sometimes those stamps are meant to be kind of like trade names, right? Like, for example, when someone takes aspirin, you can get generic aspirin or Bayer aspirin, right? Knowing that it comes from a pharmaceutical company, it's basically the same medication, but some of us will still want Bayer aspirin because it's the product that they trust in, they believe in. So from a marketing point of view, sometimes drug dealers will put their own stamp on their own drugs as well, so that if you got good stuff from them last time and you know it's from them, it'll be good stuff again in the future. Unfortunately, a lot of this stuff could be counterfeited. So if they show you pictures of the bad drugs, the easiest thing for the producer would be to just change the appearance of it, right? Or to put a different stamp on it, which means like putting a different label on it. I agree it would be helpful, but that isn't going to be, I wouldn't count on that as a safety feature.
So for people who have problems with crack cocaine, what proportion are able to successfully quit if they wanted to quit? That's
a very good question as well. treating addictions is a lot more complicated than treating a lot of other medical problems that we as physicians are used to treating, because so much of success and failure depends not only on what is going on within the body itself, but also depends on what's going on in the environment around the person as well. And so, when we look at, say, a common medical problem like pneumonia, which is an infection in the lungs, we treat it all the time, and the cure rates are very high, over 90%. And we see that effect quickly, okay? So doctors want quick fixes as well, right? And that's what we expect. And so when we don't get quick fixes, we get very disappointed, or we say, that doesn't work. Because usually with most medical problems, if it doesn't work right away, it's not going to work. Addictions is a little bit different, again, because it's not just about the medication or the treatment, it's also about what the individual, where their mind frame is at, what environment are they in. So for example, does that person's spouse still actively use when they're trying to quit? Like, who here has ever tried to stop smoking, but their spouse or partner did not? And did you ever try and quit another time where they also tried to quit? Okay. What you may find is that if you're trying to quit, but your spouse does not, and is smoking in front of you, and everything smells of smoke, and offers you cigarettes, it's going to be a lot harder to stop smoking, right? Whereas if you and your partner both quit at the same time, your success rates are going to be higher. That being said, for each individual time that someone tries to stop a drug like tobacco, the long-term, the number of people that are actually able to stop is relatively small, okay? But as with smoking, the key is you have to try many times before you get it right, okay? So for people that have stopped smoking, raise your hand if you used to be a smoker but you stopped, okay? How many of you were able to stop forever after the first time? Very, very few of you, okay? And that is true with any addiction. With respect to hard numbers with treatment of the hardcore drugs, with treatment, with a single course of treatment, depending on what it is, success rate may only be in the order of 5 to 10% the first time. It can be very low, okay? But the key is to stick at it, to try different things. In medicine, like again, in the case of pneumonia, if you have an infection and I treat you with an antibiotic and it doesn't work, there's no point in me using that again. But in addictions, it's a little bit different. The treatment may not work the first time, but if the circumstances are different the third, fourth, or fifth time, the treatment may actually work that time because some other things were different.
So there's a very high percentage of smoking cigarettes among people who are mentally ill, particularly schizophrenia. Mm-hmm. And is it true that dopamine is released in the brain when smoking cigarettes?
Yes. That complicated diagram that I showed you, one of the little receptor things was what happens with tobacco or nicotine. And so it does it in a slightly different way than some of the other chemicals do, but yes, it does release dopamine.
So AA or NA, like the 12 steps you described,
yep,
works, whereas this person wonders, does treatment doesn't seem to work. Do you agree?
Both of them can work and both of them can fail. It depends on the individual. It also depends on the context. For people, I have this on slides as well, but it takes too long to find them, so I won't try and do that again. AA or Alcoholics Anonymous is a program that has been around for about 100 years almost. And basically it's a mutual support group, okay, based on the 12 steps. And it would take, I could spend a whole hour talking about AA, but generally speaking, what you'll find is, although there are sort of general principles to AA, the way that Alcoholics Anonymous is structured is that it's not administrated from high above by one person. So there's a lot of variability or individuality from one AA group to another. So for example, if you go to if you're here in Vancouver, there can be 100 different Alcoholics Anonymous groups, okay? And as an alcoholic, if I decide to go to one, whether that meeting group is good for me or not may actually depend a lot on the actual individual people that are in that group. Okay? So one of the things I tell my patients who are alcoholics is that if you go to one AA group and you find that you can't connect with the people, you don't like it, it's not helpful, don't write off AA completely. You have to go to numerous different meetings with different people, different situations, because often it takes time to find the right fit. It's kind of like shopping for shoes, right? You don't just buy the first pair of shoes that you try on. Sometimes you have to find the right fit, and it can take a while.
So is there any help for people who are addicted or dependent to a sleeping medication, Zopiclone?
Sleeping pill addiction is very common. Zopiclone is one of the sleeping pills that people can be addicted to. Surprisingly, when it first came out, it was marketed as a non-addictive sleeping pill. And then we quickly found out that that was BS. It is addictive. With some medications, with some drugs of addiction, there are medications that we can use to target the treatment. But unfortunately for others, there are not. So things like heroin addiction, tobacco addiction, alcohol addiction, there are specific medications that we can use to treat it. But Zopiclone addiction, for example, there is no specific medication used to treat it. So that's when we have to use what we would consider non-pharmacologic treatments, support groups, similar in pattern to AA groups would be one form of that. There are numerous forms of non-pharmacologic, meaning non-medication-based treatments. Everything from one-on-one counseling to group counseling, family support, couples counseling, recovery houses, therapeutic communities, etc. So there are treatments available, but most of them are not specifically for addiction to Zopiclone.
So this is a critique. So this person's from the U.S., and unlike your historical and analytical perspectives, most discussions on addiction and drugs are not devoid of race, class, and gender analysis of oppression. So they wonder why your talk is very heavy on the medicalization rather than balancing it out, also examining social determinants of health, addiction, and illicit drugs.
So talking about social determinants of health could be a whole course in and of itself. And I did mention it briefly in some of those slides, if you may recall. So I did discuss it, but again, each of these things that I've discussed, I've only scratched the surface because each of them I could spend an hour talking about. So think of this as an introduction to these concepts.
So can sex really be considered an addiction?
That's an extremely good question as well. There's been a lot of controversy amongst scientists and doctors and addiction specialists as to what is an addiction. So for the purposes of this talk, I've focused on addiction to specific drugs or medications, for example. The question is, for example, can eating be an addiction? Can sex be an addiction? Can gambling be an addiction? When we use the word addiction in a non-medical sense, meaning people talking about the concept of addiction, we talk about sex addiction, we talk about food addiction, we talk about gambling as an addiction. When doctors talk about using that word addiction, they're talking about a very specific thing. In the old days, addiction used to refer to all of these things. There was a change or a reorganization in the way we talk about this within the last 20 years so that we limited the use of the word addiction from a physician's point of view, particularly for research purposes, to talk about just the drugs. And the sex addiction, gambling addiction, food addictions were put into a different category or label. And that's an artificial thing. For example, I may have an apple and a pear and a banana, and I may lump them all together and call them fruit, right? Or I may say, no, the banana is very different than the apple, and that's very different than the orange. But I'll lump the lemon with the orange because they're both citrus, right? So they're different labels. As we learn more about how the brain works, when we artificially separated sex and food and gambling from the other addictions and stopped calling them addictions, as we learn more and more about how the brain works, we're learning more and more about how the effects of sex, food, gambling on the brain, especially as far as those neurotransmitters, as far as the pleasure areas of the brain, they actually look more and more similar to the effects of what the drugs do, okay? And more science is showing that, yes, dopamine is the pathway for pleasure for these things as well. And when you look at long-term effects on the brain, we're starting to learn more and more about, yes, the sex addict's brain may look very different than the one that doesn't. And so again, a lot of it is starting to sound more and more similar to those for drug addictions. But what's really going to tell us more is science, right? The more we learn about the brain.
So could you explain what the structure of Canada's addiction treatment is?
No, I'm not sure if there is a structure to Canada's addictions treatment. So I guess that's probably the answer. Again, I had some slides on this, but I didn't talk about them just for the purposes of time. But when I talked about the concept of addiction being a medical problem, that is very powerful because it opens up a lot of doors. People start to feel more comfortable talking about it, as opposed to all the stigma about addictions that we've grown up with over the years, that it's a sin, it's a sign of moral weakness, et cetera, et cetera. As we recognize it more as a medical illness or a medical problem, it opens the doors to talking about it, and therefore opens the doors to talking about providing treatment for it. One slide that I do want to show to give you an example of this is when we look at, this is a list of all the medications that have been found to be effective, at least to some degree, for the treatment of addictions. And as you can see, there are only 9 of them, okay? If I were to look at the list of different medications to treat high blood pressure, there are hundreds of them. So if you look at all addictions, there's only 9 medications available. And so there's a huge disparity, okay? So part of that disparity is finding the money to do the research and finding the money to pay for the treatments available, okay? And so in the old days when we thought that addictions is just a moral weakness or a failure, et cetera, we would blame the addict, and we wouldn't realize that it's not just about saying no, okay? And now that we realize what's really going on with the brain and recognizing it's a medical problem, now rather than it's easier to relate to people with addictions because it is a disease, it is a medical problem, and therefore we may, even though I may not have an addiction, I may decide that it's important to care for people with addictions or pay for someone else to care for treatment of addictions. And so hopefully, as we accept addictions as a medical problem, there will be more groundswell of support for treatment and for looking for treatments. Showing you these medications, if we look at the list, the very small list of medications that are available for the treatment of all these different addictions, basically only one of those medications on the list is available without restrictions on it. All the other medications have restrictions. So for example, for tobacco, nicotine replacement was not covered by pharmacare until this past year by the government in BC, but only for 3 months. Same with bupropion and varenicline. Outside of that program, you have to pay out of pocket. Up until last year, you had to pay out of pocket yourself, even though we know how bad tobacco is for health. When you look at alcohol, the only medication there which is covered by pharmacare without restrictions is disulfiram. The other 2 have limited availability. And same thing with the opioids. Methadone, the main restriction is that a doctor has to have a special license in order to prescribe it, okay? And that's the only medication that requires a doctor to have a special license to prescribe. So that's a restriction of a different kind or a limitation of a different kind. So It's going to take time.
So maybe we'll have quick answers, okay? Would
It's
using a
hard
vapor...
to have quick answers.
I know. Would using a vaporizer give the same results as smoking marijuana, but would there still be same risks as smoking the tobacco?
Yes and yes.
Okay. So someone's asking, what do you think of the Smart Recovery Manual? Do you agree with Dr. Albert Ellis? I don't know who that is.
I haven't read that manual yet, and I haven't met Dr. Ellis, so I can't comment.
As a recovering opiate addict, what do you suggest for medication for pain? Person's already on gabapentin and has allergies to Demerol, codeine, and Valium.
Yeah. I'm not going to give you the name of a specific medication. What I would recommend is that you try to either find a doctor or have your doctor talk to a doctor who's got expertise and experience in treating both addiction as well as pain. Unfortunately, the number of doctors who are expert at treating pain is very small. The number of doctors who treat addictions is very small. The number of doctors who treat both is extremely small.
So maybe they could come to you afterwards and maybe ask who some recommendations?
Yeah.
So does using cocaine substantially increase the symptoms of hyperthyroid in a patient regardless of whether they're medicated for this?
The answer would be yes. Although it doesn't do anything to the thyroid itself, some of the symptoms of being high from cocaine are the symptoms similar to some of the symptoms of being stimulated by too much thyroid hormone. So they act by different mechanisms, but they can give similar symptoms.
So could someone, a victim of drug abuse, innocent victim of drug abuse, suffer a long-term emotional or psychiatric problem? I'm not really sure of the innocent.
So I'm not sure of the term innocent. Unfortunately, again, this is probably based on we as a society blaming people, right? And so, for example, if I get cancer, did I smoke? If I get lung cancer, did I smoke? If I did smoke, then I'm not innocent. I'm at fault. But if I get lung cancer and I didn't smoke, then I'm innocent. And as doctors, we don't really think that way. So it's hard for me to really answer that aspect of the question. But let me see the rest of the gist of this, because that's kind of just throwing me off here. So let's take innocent out of the question. Could someone who uses or someone who abused drugs suffer from long-term emotional or psychiatric problems? Yes. In fact, it's very common.
And does medical marijuana help with sleep disorders?
Medical marijuana for sleep has not really been studied. One thing that we do know is, I have friends who smoke marijuana. I don't know if any of you guys do, but some of my friends tell me that they use marijuana to sleep. Okay. One thing that they don't realize is that one of the symptoms of marijuana withdrawal is actually poor sleep or insomnia. Same is true for alcohol withdrawal, opioid withdrawal, nicotine withdrawal. So the question is their marijuana use helping them to sleep because it's actually just alleviating their withdrawal? A lot of people don't even recognize that they've gone through marijuana withdrawal. Like a lot of people used to say, well, there's no such thing as marijuana withdrawal, okay? But we actually know scientifically that's not true. But the difference is that the withdrawal from marijuana is more subtle. It's much less severe to the point where people may not even notice that they were in withdrawal when they were going through that. But in retrospect, when you talk to them and give them a list of symptoms, did you have this after you stopped smoking marijuana? Did you have that after you stopped smoking? The yeses start piling up, and then you say to them, did you know that you were in marijuana withdrawal? Similarly, I had a friend who had surgery on her belly, who had pain medications, opioids, and then they were stopped abruptly. I saw her about a month later, and she said, yeah, I had this symptom and that symptom and that symptom. And I said, oh, that's opioid withdrawal. She said, what? So sometimes we don't even recognize it. So it could be helpful for sleep if your sleep problem is from marijuana withdrawal. If marijuana withdrawal is not an issue, could it help you sleep? Potentially.
Okay. So I think we will take questions for another 5 minutes, and then Dr. Chan's available for a little bit afterwards if you want to speak to him.
Sure.
So this is a person whose friend has a long-standing addiction to crack, and what can they do to convince the person to stop and get to rehab?
Yeah. So let me see if I have my slide. Oh, I'm going the wrong way.
And just while he's getting the slides, for people who are having to leave now, our next talk is on February 15th, and it's Let's Talk About Thyroid Disease. And then the following talk is on March 21st, and it's about advanced care planning. Okay, so just so you know that. Okay. And this talk and all of our other talks are available on the website, the PHC Department of Medicine website. And the website icon should be on the handouts that you've had, so you can get a copy of the presentation.
Okay. I'm not going to put the slide now because it can take too long to find, but one of the things I'll talk about, just briefly mention, is something called the stages of change. Has anyone ever heard of that concept? If so, raise your hand. So what the stages of change is, it's stages of changes of behavior. We all know that changing behavior is probably one of the most difficult things to do. Okay, so for example, who's made a New Year's resolution ever in their life? Who's ever broken that New Year's resolution? Okay, that shows you how hard it is to change behavior. The stages of changes behavioral model was originally created through research from tobacco smoke. But basically what it says is that people can be at different stages in their life or in their frame of thinking as about what they want to do about their drug use problem. So for example, they may be at a stage in their life where they don't even recognize that it is a problem, even though it is. Or they may recognize that it is a problem, but have no interest in doing anything about it. And so again, there can be different stages up until a stage where they actually recognize that they have a problem, want to do something about it, and start to develop a plan, and then actually do something about it, okay? So what I would recommend this person do is do a little bit of reading about the stages of change, because it's important to figure out, for this person that you want to help, which stage of change are they in, because different strategies are used depending on which stage you're in. So if there are, let's say, 6 stages of change, it's hard to go from stage 1 to stage 6. You have to go from stage 1 to stage 2 to stage 3 to stage 4. So it's one step at a time, okay? So if you use the wrong strategy for the wrong step, it's going to be a lot harder. So that's a general recommendation. So it sort of depends on where that person's mindset is at. So it's a generic answer, but that's what I'm going to give you.
So can B15 be used in a treatment for alcoholism? Have you heard of that?
I don't know what B15 is.
Okay.
If anyone knows what it is, please tell me, and then I'll start reading about it.
Thank you. Can gaming be a substitute? Gambling be a substitute for sex? And the question is, there's a huge gambling among people of Asian origin who are in Canada. Mm-hmm. In North America. Is this genetic or cultural, or what do you?
Again, just like with addictions to other things, the answer is probably all of the above. Specifically about the question of relationship between gambling and sex, let me tell you a story. I remember about 10 years ago, I saw a patient who had a heroin addiction. We put him on methadone, and the methadone worked so well that he stopped using heroin. And then one day he came to me and said, "Doc, I started stealing." I said, "Well, what are you stealing?" "Oh, just little things here and there, like things that I don't even want or need, have no interest in selling. I don't know why. I just steal them." I said, "Well, why do you steal them?" "Because I like the thrill of trying to steal it, because there's that thrill of, are you going to get caught, not get caught?" So in a sense, what this person was doing was replacing the high from heroin, which they could no longer get because the methadone was on board, trying to replace it with a high from something else. And we do see this in 2 forms, in that when someone is addicted to one thing, their chances of being addicted to a second thing are much higher. And sometimes when one addiction gets under control, the other addiction gets more out of control because addiction, part of being addiction is that it gives you pleasure, right? It goes back to Fred Flintstone. So if we can't get pleasure from one thing, that doesn't mean that we don't want pleasure at all. We still want to get the high of being happy or pleasure or whatever it might be. So we start to look for it in other areas. And that is definitely a potential risk for people that are in treatment. So again, as a result, we find that if there is a specific medication that can be used for a specific treatment, it's not just about using that medication. It's also about using other tools to treat addictions outside of the medications, because the medications only work on one level. There's so many other levels on which addictions is occurring that need to be tackled that have nothing to do with chemistry per se.
So this may involve a long response. I don't know if we can do it. It's discuss withdrawal symptoms of different drugs.
That's an hour-long talk that I give to the medical students. So I can't explain that in one word.
Yeah. So I think we're going to have to, unfortunately, but maybe you can come speak to Alex and he can show you a resource of where you can look and find this information.
Or if you guys want to request another talk in the future,
you can say that.
You can request that.
So I'd like to thank you very much for coming tonight and asking all these great questions, and thank Alex for his time and expertise.